There we go. So we are now recording. So welcome everyone to the Strategic Prevention Framework 101 training. As I said, my name is Lisa Mason with TTAS, the Prevention Training and Technical Assistance Service Center. And Ken Plord is here, one of my colleagues, and he will be assisting as well. We are asking everyone if you would be willing to mute yourselves if you haven't already done so, just so we can keep the background noise to a minimum and make it easier for people to hear. And what you may do, if you'd like, we will take periodic breaks for questions. So if you want, you can put a question in the chat box and we will check those periodically. Or what we'll do is when it's time for questions, you can unmute yourself and ask, if that's okay. Just to let you know about the TTASK, we are one of the State Department of State Department of Education. Boy, I'm flashing back 30 years here. DEMAS. We are part of the Department of Mental Health and Addiction Services, statewide prevention resource links. The state has invested in this prevention infrastructure to support local, regional, and state prevention activities around the state. In addition to TTASK, we have the Connecticut Clearinghouse. We have the Center for Prevention, Evaluation, and Statistics. We have the Governor's Prevention Partnership, the Regional Behavioral Health Action Organizations. I know I'm forgetting somebody. Oh, we now have CERT, the Special Ed Resource Center, which is looking at school-based and assisting with school-based prevention efforts. And we have approximately 150 local prevention councils around the state. Some of them are smaller local prevention council grassroots, and some of them have received additional funding besides the state LPC grants to form larger community-wide coalitions. So that's what prevention looks like in our state. And our role is threefold. One is TTASK provides the prevention workforce development. So we provide the training and TA for prevention workers and prevention volunteers in Connecticut and to the other resource links. The second, and that includes helping people with prevention certification. The second thing we do is provide support to the state-funded prevention coalitions, community coalitions that receive prevention funding from the state of Connecticut, from DEMAS. And we also provide that on a more limited basis to folks who receive other kinds of funding, like federal drug-free community funding. And then the third thing is just to raise the visibility and the impact, raise awareness about prevention as a science and the idea of evidence-based practices and the value of prevention. Those sort of our three goals in a nutshell. And for people who are just joining, you've reached Strategic Prevention Framework or SPIF 101. We are recording this. If you have questions, please put them in the chat box and we will break periodically for questions. So that's sort of where we are right now. You can see at the bottom of the screen, our website is preventiontrainingcenter.org. And I believe most of you have probably registered through the website. Okay, so let's go to the next page. Hang on. There we go. Okay, learning objectives for today. Strategic Prevention Framework is a dynamic, data-driven planning process that prevention practitioners use to understand and more effectively address substance abuse and related health problems. Our learning objectives today are to explain the purpose of the SPIF, describe the steps, there's 5 steps, and the guiding principles, cultural competency and sustainability. Define the purpose and the key concepts associated with each step. We'll talk about the step and then we'll break it down. Identify ways to demonstrate cultural competency and promote sustainability, and access additional resources to understand your understanding. So that's pretty much what we're going to be doing today. And okay, defining key features of the SPIF. It's a dynamic and, oh boy, I always stumble over this word, iterative process, which means repetitive process. Assessment is the starting point, but we will return to this step over and over again as prevention needs evolve. And it's a circular rather than a linear model. So the idea is that rather than following a straight line, you may be jumping back and forth between steps, and that's perfectly normal as new things come up, as your coalition grows, as new substances come up like vaping did a few years ago. It's a data-driven model. It's designed to use data to guide our decisions. And that's one of the key features that we want to share with community coalition members, with community stakeholders, is we're using data to guide our decisions. Way back when prevention started, we had some good ideas, but it wasn't necessarily guided by data. And so now, as the research has grown, we're using more and more science-based, evidence-based methods, practices in prevention, and data is one of the things that helps us make those decisions. And it uses a team approach. Each step requires a team of diverse community members. And the idea of why we have a team is so the work isn't falling on one particular person like a coordinator, or it's not falling on one key sector or group in the community. For a long time, prevention was considered the work of the schools. And when we did that, it's really easy to blame the schools when prevention problems don't get addressed or resolved. And one of the things we've learned from science is taking a community-wide approach is much more effective because it shares the work, it brings diverse expertise, diverse perspectives and experience. And so the multiple partners share the work as well as the information, and they bring data with them as well. Okay. Great. Here is the strategic prevention framework, the 5 steps. And we will be talking about these in more in depth. And one of the things you'll notice is there's a lot of text on these PowerPoint slides. And please don't feel like you've got to read this all now. We will be sending this out to you later today or early tomorrow morning once we get the recording all set up. So don't feel like you have to grasp all this information, and we'll be going over it in more depth as well. But basically there's 5 steps. You can see the SPIF flower, if you will, up at the top and how it looks like a circle. The first step is assessment, and that's identifying what are the local prevention needs based on data, collecting that data and helping us identify what is the problem, helping us prioritize, look at target populations, priority substances, and related behaviors. The second is capacity, and that's capacity to implement prevention strategies, and that's building local resources and readiness. We have an equation: capacity equals resources, what we bring, whether it's people, programs, initiatives, funding, and readiness. Where is our community in terms of implementing prevention program to address prevention needs? So capacity equals resources plus readiness. Is our community ready to address these problems, and what do they need to increase their readiness? Planning is finding out what works, evidence-based strategies. This is when we identify and prioritize which risk factors that we've identified in the assessment process, and then finding the best fit strategies. What evidence-based strategies meet those risk factors and what's going to work well in our community. Implementation is defined as delivering those best fit evidence-based strategies and programs, and coming up with a work plan. Who's going to help us with that? Who's going to take ownership for those? And excuse me, there we go. And determining who our partners are and do they need any training and support to help implement parts of our prevention plan. And then the last part is evaluation, examining the process and determining, is our plan succeeding the way we hoped it would? And then we're guided by two cross-cutting principles for each of the steps. So one is cultural competence, and that's the ability of an individual or organization to understand and work with diverse groups and people in their community. And sustainability is the idea that as part of capacity, we want to sustain these prevention initiatives and these prevention resources over time. And each of the 5 steps can help us with that sustainability process. We need to be thinking about sustainability in each of those processes. It used to be we thought about sustainability at the end of the grant, and now we encourage folks to think about sustainability from the beginning. And we'll talk about how cultural competency and sustainability are involved in each of these steps. Okay. Here we go. Here's another way of looking at the SPIF prevention framework. And it just addresses what are some of these key tasks that are involved in each of the 5 steps. And we will be, don't worry about taking this all in, because we're going to go over each of them in depth, but it's another way of looking at this. And we have another handout that we can share with folks too. But this is a quick way, for example, if you're going to share this with colleagues or coalition members, this is a quick approach to be looking at it. Okay, assessment. Assessment is basically data collection. And data prioritization and reporting out on what you've learned. And you're conducting a comprehensive needs assessment here about your community. You want to know what are the substance abuse problems and the related behaviors that are associated with substance use. We're looking for risk and protective factors. For priority substances, we're looking at who are the priority populations that are impacted. We're looking at capacity, including resources and readiness, what already exists in our community. What do we have to build on? And what are the gaps? What's missing? And also community readiness. Is our community ready to support us? Or do they think this isn't really an issue and they need education or information to understand what's really happening in our town? We used to joke that on the national level, substance misuse was a big problem, but it wasn't as bad in Connecticut as it was across the nation. And then we joke or seriously say that, yeah, it's a problem in Connecticut, but it's not a problem in my town. And then we say, yeah, it's a problem in the region, but it's not a problem in my town. And what we know is it's a problem everywhere. And so having data helps to break through some of that denial. And it also helps educate people on how substance misuse has changed over time. What are the age groups that are being impacted? What are the substances most used? Where are they being used? who is using them, and what new substances are being used that maybe we weren't talking about a couple of years ago, like vaping. Like, for example, vaping marijuana, for example, is an example of how substance use has changed. And then what we're looking for is, how do we collect that data? And we use a variety of tools to do that. And the sources of data are going to come from these 12 sectors. We're going to talk about this again, and we're going to give you a graphic to look at the 12 sectors. But some of the sectors are the school system, law enforcement, hospital or healthcare, youth, parents. Did I say? Yes, law enforcement, businesses, media, government, other substance prevention or misuse treatment agencies. So those are some of the examples of where we can get the data from. And once you have completed this data assessment, it's important to share the findings with your coalition members so they have a good picture of what's happening in your community, and other stakeholders. And okay, here's some questions that guide our community assessment of substance misuse problems and related behaviors. What substance use issues and related behaviors are occurring in our community? You know, what do we see as the, you know, the primary substance that's being used? Is it poly substance use? Where are these substance use issues occurring and related behaviors associated? And some related behaviors might be, you know, use at school, you know, alcohol drug policy violations at the school. It may be underage drinking in certain parts of town. It may be DUI, driving while impaired or under the influence. It might be people presenting at the emergency room. Those are some of the related behaviors with substance use. And that helps us identify what some of the risk factors are and who is experiencing these substance misuse problems and related behaviors. Are we looking at teens? Are we looking at middle school kids? Are we looking at the 18 to 25-year-olds, adults, elders? And then breaking it down even more so, are there subgroups or priority populations that are being impacted by these? For example, in one community, they found, because they were able to do their student survey in both English and Spanish, they found people who, young people in the school system who were Spanish-speaking immigrants were using at a higher rate than their English peers. And one of the reasons why was it was culturally part of the culture to have intergenerational parties where young people were allowed to drink. And so that then became a population, both the parents and those students to look at. So that's an example. Another example of a group who may be experiencing populations could be athletes in some communities. Sometimes it's athletes. Another is looking at gender. Are there gender differences, age differences? And another is young people in the LGBTQ plus community. We know nationally, state, local, surveys have reported that LGBTQ students often are drinking, smoking, using drugs at a much higher rate than their peers for multiple reasons. So this information can help us identify and determine how to most effectively address our priority substance and the priority populations. Okay, cultural competency and sustainability and assessment, and we just talked about this very quickly with cultural competence, is here's some ways we can enhance what we're doing through the lens of cultural competence. And that's gather existing data about different population groups in your community, including those who are considered hidden or hard to reach. Collect new data to fill a gap in our understanding. Share our assessment findings with different individuals and group and say, does this reflect what you see or what you experience? What can you add to this needs assessment or to this data picture? And some of the ways that we gather data, we gather both quantitative data, which is numbers based, percentages, per capita, per 1,000 or per 100,000 people. And that is often things like student surveys or parent surveys, or it might be the number of people who have, what's the right word, participated in like DEMIS funded treatment from your community. It might be the number of emergency room visits by people that are alcohol related. Those are some examples of some numbers. The other kind is qualitative data that tells more of a story, narrative data. And we can get that data from key informant interviews, where we interview people. We use a structured set of questions where we interview a number of different people individually. And these are people who have experience and expertise to share. And it might be, for example, the school nurse at the high school or the director of nursing for the school district. It might be a local pediatrician. It might be the emergency room doctor. It might be the youth officer or the school resource officer. I'm trying to think of some other ones, but those are some ideas of interviews, key informants that you may want to talk to get their perspective and to fill out your picture. And then the last thing is just focus groups. And focus groups are used often to provide more context for data that we gather through our surveys. So for example, we may want to have a focus group of students or parents and say, these are some of the key findings. Does this resonate with you? Is this what your experience been? Or we may have some questions about further questions that the survey didn't ask. Maybe the survey didn't ask, where are young people using substances? Where are they using alcohol or marijuana? And a focus group may be able to answer that question, as well as some additional questions about behaviors. And even though assessment marks the beginning of the prevention planning process, we will go back during the SPIF to gather or collect additional data to complete our picture. And also it helps with long-term sustainable. We want to base our prevention related decisions on high quality state and local data. We want to make sure we have resources needed for prevention, and we want to assess readiness for prevention to bring our community leaders along. So one of the things that's really important with sustainability is sharing these assessment findings, sharing them with the community. This is what's happening, in our community, sharing them with community stakeholders, policymakers, letting them know this is why, prevention is important. This is what we hope to do. And just basically building the case for prevention. Okay. Step two, before we stop, is there any questions about assessment? Do people have? I don't think we have any questions. Ken, do we have any questions in the chat box?
We're okay in the chat box right now, Lisa.
Okay, thank you. Does anyone have any questions about assessment, or should we keep going? Okay, I think we'll keep going. Capacity, as we said, is resources plus readiness, and it involves building and mobilizing the local resources and readiness to address the prevention needs that we identified through our needs assessment process. And one of the things we will be looking at in needs assessment, or the assessment step, is what resources do we have? We don't want to duplicate resources with those hard-earned prevention dollars. And we don't want to step on people's toes if they're already doing a job. We don't want to duplicate what they're doing. So one of the things we want to do is see what already exists and what is missing. And then the other thing is sort of take the temperature of the community, of the community's leaders around substance misuse and their readiness to address it. I know for a long time, schools sometimes could be, what's the right word, hesitant to do student surveys because they thought it would reflect badly on them. And a lot of community coalitions say we want to use these surveys not only to take stock of what's going on in our community, but to use them as a strategic planning tool to help us plan. And we want to look at risk factors, yes, but we also want to look at protective factors. What are some of the positive things that are happening in our community? And we want to be able to recognize and celebrate those and build on those. So one of the things that we want to do with capacity is not only build the readiness and the resources, but we also want to build a prevention team or a coalition to help support prevention efforts, to drive that assessment process, to do the prevention planning, and help sustain prevention over time. So here are some of the strategies for building local capacity: engaging diverse community stakeholders, letting them know what you're doing and engage them in the effort. Develop and strengthen a prevention team or coalition. This can be your local prevention council or community coalition, and raising community awareness about that and identifying resources which are available. Okay. And when we talk about capacity, you'll hear the term 12 sectors. And these are the 12 sectors that both DEMAS, Department of Mental Health and Addiction Services, and the federal government, SAMHSA and CDC, recommend that we bring in to our community-wide coalitions. And this is, again, a graphic that you can share with folks. It starts with youth. Youth are the ones being impacted often with our prevention programming. So we want to hear their voice, their views, and they can be leaders in helping to determine what we do and how we do it. Parents are important because we know parents are one of the #1 influences on whether kids use or don't use. We know kids report that parents who talk to them, that's like the #1 influence on them not using. Businesses have a role to play, the media, in publicizing what we're doing. And one of the things that we're doing now more and more is using social media to communicate our needs, our strategies, our successes. Schools, because that's where kids live almost a third of their day. And they're an important partner in teaching skills and information. Youth serving organizations are often usually a partner. Sometimes that's where the coalitions are based, in a youth service bureau or youth serving organization. And they are partners in helping us target youth, again, having expertise in terms of working with youth. Law enforcement is another one. Civic and volunteer organizations, religious and fraternal organizations, healthcare, state, local, or tribal government, and then substance abuse prevention or treatment organizations. 2 other groups, or actually 3 other groups that you don't see here that some communities have involved, is the military. If they have military representation in their community, they've invited them. Another one is the recovery community, people who are in recovery from substance misuse, or maybe parents of a young person or adult in recovery. And then the third one can be members of LGBTQ groups, because they have that expertise as well in terms of the lived experience and understanding what kids need. So those are some of the different groups that come around the table that share their data, their information, their expertise, and help us think about what are some of the strategies we should select. And again, we need to think of cultural competence and sustainability. We want to recruit prevention partners from diverse community sectors. We want to connect with high risk and hard to reach populations and recruit representatives from these groups to join our coalition. That one community that I mentioned earlier that saw the difference in Spanish speaking versus English speaking kids, what they did when the first thing they did was recognizing they had a significant number of Spanish speaking kids who were recent immigrants, was they connected with the Spanish speaking center in their town and said, can you help us translate this survey? So we are making sure we get input from all kids in our high school, in our community. And then can you help us connect with, parents and kids to share this information and to translate it? So that's one example of culturally competent practices. Help your coalition learn more about your focus population and help them learn about the diversity and the cultural competency itself. And then many of these capacity buildings support sustainability, and that's engaging partners and tapping resources from diverse community sectors, building widespread community awareness and support, cultivating champions among influential leaders in decision makings. In my community, we were fortunate that we had the director of the local YMCA, who was incredibly well respected in our community. He saw this as an issue, big commitment to youth development. And so he was able to bring a lot of people on board. He has since retired. His predecessor has taken over that role of community champion. And a second community champion has been our deputy police captain, our deputy police chief. He's a real youth advocate. And he's also the one who, when we question whether or not we should be doing something or whether it might ruffle feathers, he says, hey, it's about the kids. And he's the one who often goes up in front of community policymakers, the town council, the finance board, and says, hey, this is important. This is why we need to do it. This is why we're asking your help. So finding out who those champions are, who can speak on your behalf, and then building coalition capacity over time. To understand the SPIF, to understand what evidence-based practices are, and to help build their ability to partner with you. Again, do they need training or technical assistance or support to implement different practices and programs? And by building and mobilizing, local capacity, we're creating that foundation or that prevention infrastructure. Okay. Any questions about capacity? And if you do, just let us know. It's fine to interrupt, turn off your mic and ask a question if you'd like. In the meantime,
nothing in the chat box, Lisa.
Thank you, Ken. Thank you. One of the things that I like to tell coalitions is capacity, just like we said that you jump back and forth sometimes between the different steps, capacity is like a train that's running on a parallel track to the other SPIF steps. We often are in a rush sometimes to think about, okay, what are the needs? Let's come up with a plan and implement it. And capacity is something that that builds over time, because coalition members may come and they may go, new substances may come up, we may look at a new strategy that we want to try and have to involve a different group in the community to help us with that. So it's like we've got our planning, implementing prevention strategies train going, and on a parallel track, we've got our capacity going. So it's like we're driving two trains almost at the same time. And sometimes we can get really caught up in the planning, implementing, that we sometimes forget about the capacity building. So it's good to take stock of that capacity, taking time to check in with them, reflect with them on what we're doing, celebrate with them, see what other kinds of topics or training that they're interested in. Okay, now we'll jump into planning. Planning involves how to best address those specific prevention needs and associated factors and behaviors. To develop a solid prevention plan, we need to prioritize the risk and protective factors, which we're going to talk about in a minute. We're going to select appropriate interventions to address our priority risk and protective factors. We're going to combine those interventions for a comprehensive approach. One of the things that we've learned from prevention research is prevention is an ongoing process. It's not a one-time event or program and then stops. For example, we may want to bring in a big name speaker to motivate people and mobilize the community. And some people might think, okay, they talked to the kids and the parents were done. No, that's sort of the beginning, or that may be a way to revitalize, but we need things to continue after that. And we also need multiple interventions that reinforce each other. So a really quick example might be, I want to launch a social marketing campaign that's going to educate parents, say, about social hosting, because we know parents' perception and kids having easy access to alcohol, at home are a big deal in our community. That came out of our data collection. And so we want to develop a social marketing campaign that's going to teach parents about the social host law, why it's important, the developing adolescent brain, and how they're really vulnerable to alcohol and higher vulnerability to addiction, and to reinforce that social marketing campaign. Maybe we're going to have some community forums, or we're going to have some parent education, or we're going to train some young people to speak to parents, or we're going to ask the school system to put a column in the local PTA newsletter or principal newsletter about what we're doing. So those, or ask the library to stack to set up a display of books, or put a display in the town hall or someplace people frequent. So those strategies are reinforcing. So those are the multiple strategies that we're combining, partly for a couple of reasons. One is not everybody's ready to hear the message at the same time. Also, the more we reinforce it, sometimes, what do they say? It takes like 7 times to hear a message for it to take root. And also, we're catching people in different places, in different times. So that's another reason. So we want to combine those interventions. And then what we're also doing is building and sharing a logic model with our stakeholders. And a logic model is basically a roadmap. It says, this is the substance misuse we're most concerned about. It logically connects to the risk factor that we're targeting, which is supported with data. It then says these are the strategies that we are going to use to address these risk and protective factors, and these are the outcomes that we're looking for. But this logic model helps explain why we're doing what we're doing. It's the rationale. Okay, risk and protective factors. This is something that you'll hear a lot about in prevention. And one of the things that we target, it's hard to target alcohol or other substance misuse in itself. And what we do is we look at the risk and protective factors. Hawkins and Catalano back 20, 30 years ago, were two of the prevention researchers. They're based at the University of Washington, came up with a social development model, a social development strategy, did a lot of early research in community coalitions. And what they found, they were curious, why are some kids in a family getting involved with alcohol, drug use, juvenile delinquency, dropping out of school, and other kids in the family aren't? That was sort of the question they were looking at. And what they came up with was the whole idea of risk and protective factors, that kids are exposed to different risk and protective factors. And protective factors actually reduce the probability of a young person getting involved in risky behaviors, and provide sort of a protective shield or support to them and help them promote more healthy behaviors. And risk factors are those, doesn't guarantee a young person will get involved in risky behaviors, but those are more associated.
Yes, yes.
And what we see is those risk and protective factors can be divided into different spheres of a young person's life. So they are related to family, they are related to school, to peers, to neighborhood and community.
Okay, so when will I be able to like contact my insurance to find out how much it's going to cost me?
Okay,
like when will that go through?
I think somebody may be on the phone. We can hear you. Thank you.
I booked it for Tuesday, which is why like the insurance was like, can you ask them to send it as urgent?
Might be
Because otherwise they
Kelsey.
said it could take like 2 to 5 days.
Hey,
Maybe.
Kelsey, I think you may be on the phone. Thanks. Thank you. And so that's where the risk and protective factors, and there are risk and protective factors documented with research around alcohol, marijuana, and other substances. And those are what we target with our prevention strategies. And when we're looking at those, when we're looking at related behaviors, when we're looking at where, when kids or adults are using substances, that helps us identify what those risk and protective factors are. And we prioritize those risk and protective factors by looking at their importance. How much does this risk and or protective factor contribute to or protect from the priority substance misuse problem? Is it relevant given the developmental stage of our focus population? Is it associated with other behavioral health issues? Because one of the things we find is when we focus on one risk factor, maybe related to alcohol use, it can be related to other things like dropping out of school or teen pregnancy or mental health issues. And then the other thing we're looking at is the changeability. We want to look at how easy is it to change, because if it's going to be really hard to change that risk factor, we may want to look at something else and have success somewhere else and build the confidence and build the success so we can target that. So we're asking ourselves, do we have the resources and readiness to target this risk factor? Is there a suitable intervention that addresses this risk factor, and can we produce outcomes within a reasonable time frame? So it's best to prioritize, if possible, those that are both high in importance and high in changeability, if possible. But sometimes we look at high in importance and maybe a little bit lower in changeability.
So Lisa, I have a quick question, if possible, about the risk factor. So I'm very new to this in regards to engaging in prevention work. So when we're talking about risk factor, and if we need to change it, right? So we're community centered or client centered in regards to meeting the needs of where they're at. Can you give me an example, please, of how in the work that we are implementing, how would we go about, what would be an example of changing a risk factor, for example?
Sure.
Thank you.
Great question. Thank you. And one of the things I want to remind people too is this training isn't the end of our discussion on this. You are more than welcome at any time to email us, phone us with questions or schedule a time for further discussion. So that's part of the technical assistance we provide as well. So an example of a risk factor, we talk about when we're collecting data, 4 core measures. And I'm keeping an eye on my clock too, because I'm in step 3, so I'm doing okay. We talk about 4 core measures that we collect for each substance. One is past 30-day use, and that's the definition for current use. So we ask kids about whether they've used a substance in the last 30 days, and that's the state and federal government definition for current use. So that's where we get the idea of use. Then we ask about 3 risk factors that are associated through research with substance use. One is what is a young person's perception of risk associated with a substance? Do they perceive it risky? Because the more risky they perceive that substance, the less likely they are to use it. And when their perception of risk goes down, often what we see is a follow-up increase in use. And I'll give you a quick example. One substance that is perceived risky by kids all over the state, all over the nation, is tobacco use. Kids have gotten that message loud and clear. You'll see anywhere from like a 90 to 98% of young people reporting that they see tobacco use as very risky. And you'll see the flip side, the inverse in terms of use. So you'll see kids who are reporting tobacco use in the last 30 days, depending on their age, it increases as they get older, but it may be anywhere from like 4% to maybe, 8%, maybe, 15, 20% as they get older, but that would be really high. A flip side of that would be marijuana use. What we have seen is the risk of marijuana, the perception of risk associated with marijuana use has decreased over the last several years. And we attribute that to more states legalizing use for adults. So kids think, oh, it can't be a problem if the state's allowing you to use it. And now we're facing that in Connecticut. With medical marijuana use or the use for medical reasons. And again, kids think, well, it can't be that bad. If the state is saying you can get a prescription for it, and that's not what the state is saying. The state is saying you can be certified to use it. If your doctor says the benefits outweigh the risks, but that doesn't get translated to young people usually. And as that perception of risk has decreased, the number of kids using has increased. So what we find now is more kids are using marijuana than are using tobacco, for example. And so it varies. Your high school seniors, you could be having anywhere from, 20 to 40% of your high school seniors have used marijuana in the last 30 days. So that's an example of risk and protective factors. The 2 other 4 core measures that we talk about that we like to see in every survey that are being done by kids and that the feds and the state require, 30-day use, young people's perception of risk, young people's perception of parent disapproval. And we talked about this a little bit earlier. The more a young person perceives their parents as disapproving of using a substance, that's a protective factor. When young people report they don't perceive their parents as disapproving of their use, then they're more likely to use. So that's another example of a risk and protective factor. And then the last one is youth's perception of peer disapproval. The more young people say, my peers disapprove of this, the less likely they are to use. When they say my peers are more likely, I'm using a double negative, to not disapprove, to approve of it or be okay with it, then they're more likely to use. And we know that young people tend to use similar to their friends, their peer group. So does that help answer your question?
Yes, thank you very much. I appreciate it.
And then what we would do is develop some prevention strategies that target those specific risk and protective factors. And it might be educational strategies, it might be social marketing, it might be training teachers to teach a curriculum that has those, risk and protective factors that takes that into account. So those are some examples. Okay, let's see. And thank you for that question. So when we're planning, we want to prioritize the risk and protective factors. So we want to say, what are the risk and protective factors that are happening locally? Why is substance use a factor or a problem in our community? What are some of the factors that are contributing to that? We just talked about importance and changeability. And so this is another way of looking at what we just talked about. Okay, and planning is basically identifying what are the priority risk factors and then selecting appropriate strategies. And what we want to do is choose evidence-based strategies. We want to pick prevention strategies that are evidence-based, that have documented evidence, research that shows they're effective in targeting the specific risk factors, in targeting the population that we're working with. And that's where conceptual fit comes in. Is it a good conceptual fit? If it addresses one or more of the risk factors that we're looking at, or enhances the protective factors, if it looks like it has positive outcomes for the population, and the population could be the age, it could be racial, ethnic identity, it could be LGBTQ status, gender, it could be, for example, kids in military families. I don't know, I'm guessing right here. And then does it have practical fit? Is it something we have the capacity to do in our community? Does it fit in what we're already doing? Or if not, can we provide the supports needed? Do we have the funding? Can we provide training and technical assistance to support this? Is it appropriate for our community? Is it going to work here? And then can we provide the supports to make it happen? So that's what planning is. Okay, and this is one where the logic model, we create a logic model during the planning phase. And a logic model is, which I've described a little bit earlier, is really a great way to check on the conceptual fit. Is what we're choosing going to target that the risk factor. So for example, in a community, they wanted to target their target population was kids, but parents, and they were looking at things to do with parents because they wanted to educate parents about the social host law. They wanted to educate them about the developing brain. And one of the strategies they came up with was youth presentations. They had a good track record of doing a freshman forum and having older peers go and talk to younger peers. And I said to them, those are well and good strategies, but how are they connecting with the risk factors you just identified? And the person said, but people like these. And I said, I agree. People like those. And you can continue to do those because they're well received and people like them, but they're not going to help you with those risk factors. Maybe they'll support them. I don't know. Or maybe there's something else you continue doing, but you need to look at things that are specific. So then they came up with things that would educate the parents, that were more targeted to parents and less to kids. So that's an example of conceptual fit and how you can use that logic model. The logic model was a great way to point that out. And it's a great way to also explain to coalition members who may have their heart set on doing something that doesn't fit with what you're doing, or may want to do something that they remember from 20 years ago when they were in high school. Okay, selecting appropriate strategies. This is just another way, more text-based way of talking about what we just talked about. Here's our logic model. A logic model is a graphic planning tool, much like a roadmap, that can help your team communicate where you want to go and how you intend to get there. And it includes the substance problem and related behavioral health, related health behaviors or behavioral health, and that's supported by data. And what are the associated risk and protective factors that we want to look at? And those are supported with data. And then what strategies, activities, interventions do we want to implement that are going to target those risk and protective factors? Excuse me. And then what outcomes are we looking for? What changes do we want to see? And we'll talk about those when we talk about evaluation in a couple of minutes. And those outcomes are based on some of the initial data. So you want to look at outcomes that are reasonable to get in a specific amount of time. Say your grant is a 3-year grant or a 5-year grant. They may be short-term outcomes, which could be related to the risk and protective factors, or they could be longer-term outcomes, which may be like 30-day use. And that may be something that's hard to do in a like 3-year grant, but you might be able to see some changes in a 5-year grant, depending on the strategies you pick. When developing a logic model, it's important to work with an evaluator to identify a set of anticipated outcomes that are clear and measurable. So for example, maybe we have our initial data shows that 25% of our 9th to 12th graders have used alcohol in the last 30 days. And we want to get that down to 20%. For example, that's something we'd like to see over the course of 5 years. And that's clear. We've identified what the measure is, what we want to see. We have a time frame for it. And maybe one of the risk factors is perception of harm. And so maybe the short-term outcome that we're looking at is we want to see a perception we want to see a change in the perception of risk. And maybe, I don't know, 80% of young people saw alcohol use as a risky thing, and we want to get that up to 85%. So those are some examples. And as we said, we have short and long term. Short terms are the most immediate effect of an intervention. How closely are they related to the intervention? So these are often process outcomes. They're often changes in knowledge, attitudes, beliefs, sometimes skills, and they tended to, oops, sorry about that. And they tended to be connected to changes in priority, risk, and protective factors. Long-term outcomes are the ultimate effects of the interventions after the interventions have been in place for a specific amount of time. And these usually come from, they are a result of the short-term outcomes. And these are usually tied to, they could be tied to like 30-day use, measures of substance use, or they could also be tied to changes in our community. Like an example might be, we were able to get a prevention coordinator funded by our town. That's a huge outcome. That might be an example of an outcome. Or now we have, we have put in, I don't know, a town ordinance or something that we now have, a standing prevention coalition that reports annually to the mayor or the town council or whatever. So those would be some examples of some longer term outcomes. Okay, cultural competency and sustainability in planning. Planning activities help ensure that our prevention efforts will be culturally competent. So we use the assessment data from diverse community groups to make planning decisions. We include focus population members, focus group members as active participants and decision makers in the process. So say we want to impact young people's perception of risk, we're going to want to talk to some young people and say, we're looking at a social marketing campaign. These are some of the things we're doing. What do you think about a social marketing campaign? And can you help us pilot test some of the messages or some of the graphics or visuals that we want to use in this process? And incorporating prevention interventions that are appropriate and specific to high risk and different cultural groups. And they also, planning activities can help support the long-term sustainability. Using prevention data to determine which risk and protective factors in order to have the biggest impact. For example, if we're not targeting priority risk and protective factors, but targeting something else that's a lower in the scale of priority, we're not going to get to see the changes we want in substance use itself. So people are going to say, well, we didn't see the change, so why are we investing in this? Why are we investing our time or our funding or whatever? So that's again why we're addressing priority risk and protective factors. Identifying evidence-based ones. Again, we want to make sure that the effort we're putting into the work is going to have the best bang for the buck, to be the most effective, because that helps people see that the work is credible, that it's worth investing time and funding in. And selecting interventions that the community has sufficient capacity, that they're capable of doing. An example in one community that some people may be aware of is the asset-based classroom. And that's something that Southington Coalition worked with the school system over time. And now the school, and they provided lots of training on developmental assets, on the survey results. They found a champion, a guidance counselor to take the lead with a member from the coalition. And now, after 7 or 8 years, the school owns this. It's their thing. They're proud of it. They talk about it on their website. But that was only because the coalition provided a lot of training, provided technical assistance, provided, we're in this with you, we're going to help you. And they still provide annual training for it. They help the school with that. So there's an example of, a community didn't have sufficient capacity to start something, but the coalition was the catalyst to help them do that. And then make the planning process transparent and inclusive by sharing information, inviting participation from key stakeholders. That's another way to help sustainability, making sure the community knows what we're doing and inviting them in. And then step 4 is implementation. Then that's basically putting your strategic plan into action, taking your logic model and the strategies that you've selected and coming up with a work plan. Who's going to help you do this? Who are your implementation partners? If you're doing something, that's school-based, you want to make sure you've got some educators working with you. If you're doing law enforcement strategies like compliance checks, you need to connect with local law enforcement and make sure they understand the need for this and they're ready to work with you. If they're interested and willing, but they don't have the expertise, who can you call on to help train train them and work with them. Another community that we work with, they worked with the police over time, and before the grant ended, which it did in June, the police said, we're going to take over all the enforcement activities. We believe in these. We've seen how we can incorporate these into our regular work. We've got it. So that's a way they sustained some strategies over time. And then fidelity and adaptation is important to get the best effectiveness for our strategies, the best outcomes and results. We want to implement them as close to the way they were developed and shown to work through research. And so that means understanding what's involved, making sure people get training in TA. It means if I've chosen a 10-session curriculum to teach to middle schools, that I'm not teaching it in 5 sessions, or I'm not leaving stuff out because I'm not going to get the outcomes that I wanted. And then adapting it. Sometimes we need to adapt. And it's like, am I delivering the key components? How much am I changing? What am I changing? And if you're not sure, check with the program developer or check with other people who have implemented this. Sometimes we need to adapt it because of the groups we're working with, some of these underserved populations. For example, we may want to translate a curriculum or translate, some social marketing. And so we may talk with somebody about that. So any questions on implementation? And this is where we can bring in cultural competence and sustainability and implementation. We want to identify interventions with documented effectiveness for our focus population. We want to involve focus populations or target group members in the planning and implementation of the prevention interventions. We want to identify stakeholders and partners to select and implement preventions that's a good and comfortable fit for our target population, whether it's youth, parents, police, teachers. And then how it helps support the long-term sustainability is ensure that our prevention strategies are evidence-based and part of a bigger comprehensive plan, that we are increasing the cultural relevance of our prevention strategies without compromising their effectiveness. We're working closely with our partners to build their capacity, their confidence and comfort level to implement strategies and to help evaluate them. And we're reaching out to other implementation and community sector partners to increase support for prevention. And finally, one of the things that's really important, and it's hard to see, I'm going to see if I can move this, is celebrating our success, celebrating the small wins that occur from implementation and note progress. And so whether that's, thanking people who participated, having a little celebration occasion, reporting out at like a town council meeting or a board of ed meeting on something that's going well or a success that you've had. Those are some different examples. Okay, and evaluation, that's our last step in the SPIF. An evaluation exam involves examining both the process and the outcome. Evaluation is the systematic collection and analysis of information about our prevention activities to assess whether we've achieved our goals and to also help us improve our effectiveness, at delivering and implementing these strategies and make decisions on how we might adapt them, for the future. Whether we find that one of the strategies we picked, we aren't having success with that we anticipated. So let's go back and look at how we implemented it. Did we make some changes that might have, impacted the effectiveness, or did we not maybe choose the most appropriate strategy? We need to go back and look at something else. Or maybe we had a strategy that we thought would work, and we had some initial agreement to implement it, but because of other things going on, it wasn't implemented the way we wanted to. I'm going to give you a really quick example. Sometimes people will check enforcement, and as many of you know, in Connecticut, larger communities have their own police force who can help with that. Much smaller rural communities have a resident state trooper. And the resident state trooper may be too busy. Sometimes they are able to help with the enforcement strategies, but sometimes they're not. So maybe the enforcement strategies don't fit the practical fit of our community. Or maybe there was a change in police chief and the original one agreed to it, but the new one, doesn't have a good understanding, or it didn't go well in his previous town or something. And he says, no, we're not doing that. And so then we got to go and look back and say, okay, we got to look at a different strategy, perhaps. Or do we want to bring up increases community readiness by connecting him with others, police chiefs who've had success with this? So process evaluation documents the implementation of an intervention, and it can be used to improve our delivery, to make mid-course corrections, and enhance the understanding of our prevention outcomes. So basically, it's what we did, when we did, how many we did, how many people that we connected with. Did we implement it as we expected to? Those are some ideas of process evaluation. Process evaluation too is looking at some of those risk factors. And are we seeing the changes in like perception of risk or parent disapproval that we were hoping for? Because if we're not seeing those, maybe we need to change the messaging in the social marketing campaign, or we need to find some other ways to connect with parents, or we need other people speaking to the parents who they can relate to better, being a spokesperson, like for example, for a campaign. And then outcome is measuring whether it's having the longer term effect that we're looking for. And that helps us not only build our confidence that we've selected the right strategies, but it also puts us in place to leverage additional support, whether it be funding, whether it be community support, additional volunteers, local funding, additional grants. Those are some examples. Middlesex County, with their United Way, probably 15 years ago, started something called their youth development project. And they said to each community, we'll give you $10,000 to build youth development activities if you agree to do the Search Institute student survey. And I think all but one community agreed to do it. And they did this over time. They did youth development activities. They got to learn more about developmental assets. They collected data over time. And because they had that data that showed some positive changes, that set them up for state and federal grants. So they were able to leverage those $10,000 grants over time, year after year, into $100,000, $125,000 grants. And that's partly because they had a story to tell and a story backed by data that was collected from evaluation. So that's an example of a real success story using your evaluation. Okay, evaluation types. We just talked about process and outcome. So process is basically, did we implement it the way we anticipated? How many people did we impact? And then we're looking at outcome, which is short-term and long-term. Short-term is more the risk factors that we're looking at. Long-term is more the changes in substance use or misuse. And then evaluation and communicating our findings. One of the things we want to do is communicate those evaluation findings, because number one, we want to celebrate the good work that we're doing, and we want to build we want to increase that community readiness, that prevention is effective and it works and it's worth investing in. So we want to discuss the evaluation results with coalition members first, so they can understand the progress we're making. They can help us improve our program, celebrate success, and they can serve as spokespeople in the community and with policymakers. You can submit a short press release to local newspapers, or you can put bits of your data online. Well, you can put your evaluation report like on a website, but you can put sound bites like on social media, and then say, if you want to learn more, go to our website for additional information. You can develop different kinds of community presentations for different groups, or convene a town hall meeting to say, hey, this is what's going on with our kids. And what some communities have done is they've trained the kids and prepared the kids, the youth members of their council or their youth council, to provide the information, to do the presentation. You can create fact sheets or infographics on key findings. And use that on your websites, send them out to emails, share with social media, share with educators, or with law enforcement if they've been involved in the strategies. You can create a full evaluation report to share with funders, and you can explore the findings and think about the next steps. Okay, we worked with our students as a whole. What do we need to do now to look at different subgroups within, say, our high school population, and who can help us connect with those? So those are some different ways you can communicate those findings. Somebody once said, all data tells a story, and you need, and you can't tell a good story without data, or something like that. Ken, you can correct me if I mangled that. But the whole idea is data helps make our stories more realistic and grounded in what's happening in our community. But we need that data to be able to tell the story. Okay, how do we use cultural competence? How does evaluation help enhance cultural competence and sustainability? Evaluation methods can be used to identify if our strategies and activities are having the intended effect on target populations and any health disparities that we may see. We can schedule follow-up meetings with priority population groups, and ask them, maybe a focus group of some members of the target population, and ask them, what was it like participating in this particular prevention strategy? What would you recommend that we do a little differently? And then using those results to guide our future programming, with maybe modifying our goals or setting new ones, securing funding, determining how we're going to allocate our resources. Okay, we have a quiz here and I forgot to load it, so don't worry about that. I'm wondering, do we have any questions based on, and we have an action planning tool that we've developed that breaks the 5 SPIF steps into key tasks, where you can report progress and challenges, and you can put a due date on it, and you can share it with coalition partners. And I'm not sure if it's in this. I forgot. Okay, that's different. We don't have it here, but what we're going to do is we're going to send that out to you. And it's a way of providing coalition members a report of where we are with the 5 steps, the 5 SPIF steps, and what is, and what are the next things? What are the next priority tasks that we're working on? And we will share that with you. And any tools or templates that we provide are things that you can modify any way you like. You do not have to use them the way we've developed them. We've taken it based on advice and things we've seen from other coalitions or staff members have used when they were coordinators. And we've tried to mash them up to become user-friendly. But you may say, I want to change this because it meets my needs better if I do this. And we thoroughly support that, you adapting them.
If you'd like, Lisa, I could pull up my screen real quick and just show what that looks
wonderful.
like.
Wonderful.
you may have to
Stop.
just need permission to,
All righty.
let's see here. Okay, so I believe that is the
Yes, it is.
action checklist.
Thank you so much, Ken.
Oh, no problem.
So you can
Maybe-
see where it's breaking down into 5 steps. And, you know, it talks about the key tasks, you know, what is the progress, you know, what challenges are we having? What's the due date? What other people have done is they've taken this and they may even produce a second copy and only focus on the steps that they're doing at the time. So maybe they're focusing at the beginning at just assessment and capacity. So they may copy and paste that onto another Excel sheet or Word document, and then they may put some subtasks in there, and then they may create an implementation plan. You know, what's the date that we intend to do that? Who's responsible? You know, what are some specific things we need to do? Do we need to offer training or TA? Do we need to contact somebody? And then that becomes a reporting tool as well. And we can share a copy of an implementation tool if that's something people want to see. Okay, thank you, Ken. Okay. And I think we lost it. Hang on. Just a second. Okay. We were here. Okay. Okay, we have 2 appendices here. One is, these are some opportunities to integrate cultural competence into each of these steps. And these are things that we've talked about already, plus some additional things. So this is just for your reference. And then we do the same thing with sustainability. We give you some ideas of how you can integrate sustainability or use the different steps to enhance sustainability. So these are something for your reference tool. And then one of the things we do, because people are coming from different parts of the state, is we share the 5 regional behavioral health organizations. And as you can see, the state is divided, and some of you may be familiar with these already, but some of you may not. We divide, the State Department of Mental Health and Addiction Services has divided the state into 5 regions, and these align with the 5 treatment behavioral health regions, but they've also done this for prevention work as well. And each of these organizations serve a different region. So the hub serves Southwestern Connecticut, Bridgeport and Lower Fairfield County. Alliance for Prevention and Wellness serves Greater New Haven, Middlesex counties. Let's see, CRAC serves all of Eastern Connecticut. Amplify serves Greater Hartford and a bit of Tolland County. And then the last one, Western Connecticut Coalition, serves Litchfield and Upper Fairfield County. So if you're looking to find out what else is going on in your region in terms of prevention, we encourage you to connect with these folks, get on their email lists. They provide more regional-based training and TA. They are the ones who administer the local prevention council grants for DEMIS. So you may already be serving as a local prevention council, but sometimes there's coalitions that have been funded that aren't connected with their local prevention council. And so they can tell you who's the local prevention council that's serving your community. But definitely connect with them if you want more information. It's also a way to network with other coalitions or local prevention councils in your region. Many of them have like quarterly or monthly networking meetings in addition to training. So we encourage you, if you haven't already connected with them. And we already mentioned the Connecticut Clearinghouse. And the Center for Prevention Evaluation Statistics, we can send you their contact information. They are the ones who provide assistance to coalitions on all things data collection and evaluation. Usually state and federal funded coalition grants require that a portion of the funding be set aside for an evaluator, both to guide the work, create an evaluation plan, help with that logic model, and then produce some evaluation results, collect the data and prepare an evaluation report, with the idea that it's a check on what the coalition is doing to help them grow their capacity around evaluation. Make sure that the coalitions are getting the best outcomes for the work that they're investing in, but to also to be able to tell that success story, so then that sets them up to leverage additional funding as well. So that's one of the reasons to have an evaluator if you can afford it. Generally, with a local prevention council grant in Connecticut, there isn't enough money because those are much smaller. Those range anywhere from, I'm going to guesstimate, 4,000 to maybe 15,000, depending on your population. They're based on your population. I know they've grown somewhat because of the additional federal funding coming from SAMHSA regarding COVID and mental health and substance misuse. But in the past, they were anywhere from like $3,000 to maybe $10,000, and they've increased somewhat. Okay, and then these are resources and citations. One of the things you can click on is if you want to read a guidebook to the SPIF that's in more detail, you can click on this. We're going to send you these prevention slides. You won't find it if you go on SAMHSA's website now, because they archive some of their older files, but a lot of us like this, and we were able to sneak around and find where they put it in the archive. So here it is. Often when they stop a contract with one national TA provider, they'll archive those files and then start fresh with a new TA provider or trainer. And it makes us in prevention a little crazy, because if it's good, why throw it out, right? We have the action template that we're going to show you. Many of you may be familiar with CADCA, National Coalition Institute, and you can join as a member as well. CADCA is the Communities Anti-Drug Coalition Association, and they are the group that provides training and TA to any coalition funded with the federal drug-free community grant. There's our TTASC website, Prevention Training Center. There's myself and Jennifer, who helped design, did the initial work on this presentation, and Ken is available as well. We will put his email in the follow-up email that we'll send. Shay and David as well, or two other staff members. Ken's email is plourd, PLOURD @xsector.com. And we are just at 11:30. Do we have, oh, thank you, Ken, he just put it in. So we will be emailing everybody a PowerPoint presentation. We will be emailing the action template and a link to the recording of this. And so I think that's it for my presentation. Are there any questions? Or have I overwhelmed you with information? Oh, I forgot to mention there's 2 pages of glossary here with different terms. Okay. Okay. Do we have any questions, or have I overwhelmed you with information?
If you think of a question at a later point, definitely feel free to email us too, because
definitely email us. If you want to set up a time to, talk some things out, we can do that as well. That's what we're here for.
I don't know if my mic works. Can you hear me?
Yes, I can, Ramona.
Oh,
hi,
yay.
nice to see you.
Thank you. I just got a new headphone and last time I tried to use it, it did not work. So
Okay.
I just wanted to mention that you mentioned great local health initiatives, but I just wanted to mention about how the local health departments
Thank
are kind
you.
of a new partner in all of this because we've been trying to get them up to speed on embracing different prevention activities like this for training,
Yep.
especially with substance abuse, because it is something that was out of their wheelhouse before. But I think that this kind of structure is fabulous and would love to see more of their staff engaged in doing this kind of work.
And that's what we're seeing. I think because of the opioid, the SOAR grants, state opioid response grants that have gone to health departments, they are connecting more with coalitions. We have health departments sharing information, and we have some coalitions that have health department members participating in their coalition. So that's really exciting.
Some of the funding those from Department of Public Health as well. So
Yep.
this is the Overdose Data to Action grants. We have multiple health departments and districts involved.
Yep. So yes, health departments, and they're a great source for data too, when you're doing that assessment phase.
Definitely. So thank you.
Sure. Any other questions or comments? You're welcome to turn on your mic and talk. And if not, that's pretty much the end of the content. So let us know. We will be sending out, once we upload the training recording to our YouTube channel, we'll get the information out to you. And
Thank you, Ken and Lisa.
excuse me?
Thank you.
Oh, you're welcome. You're welcome. And one of the things we talk about with people too is you may want to do a quick spiff presentation for your coalitions, and you're welcome to take anything here, and we can help you create a smaller one too. We've done that before. So I hope everyone has a good day. And thank you for your participation. Usually, Ken, I take attendance at the beginning, but I did not do that because I was talking. So one of the things we can do is, in terms of CEUs, is we can look at
We'll go back to the participant list.
Yeah,
and
we'll go back to that list. I have one that was created last Friday, a registration list, and I can add anybody that's new onto my list. And then we'll look at the Zoom participation list. So we can figure that out both for CEUs and for our impact recording as well.
Yeah, and let's definitely connect, and I'll also give it to Shay as well, because I don't know if she's sending out a follow-up, or are you doing the follow-up email?
You know what? I just assumed I was, but I can check with Shay. I'll check with Shay.
Just because I have a few folks that I'm going to have to add to the list because there was something a little wonky with the link.
Okay.
Or it could have been an email address, but I have to go back in the LMS system and just make sure that we have correct email addresses for a few.
Now, with our website that we're working on, the new one, we won't have the LMS. We'd have to still use the old LMS until we.
Correct. I think we're trying to figure out the solution to merging that without having to maintain two websites.
Okay. So what I can do is I can go in to the registration page and check off the people who attended. And at this point, I don't think we have the CEU template in there.
No, it's still, we don't have that capability yet, but I think that will still have to go through Mark probably to do that.
I wish we could design the system to go back and do that, because you send them out, it automatically sends them out.
I know. Yeah,
so maybe we'll bring that back up.
Yeah, for sure. And I mean, I can create those templates, are very easy to create too. And I mean, if we can get them automated, it would make everybody's life so much easier.
Yeah. Yep.
I have to run right now just because I have the ECHO meeting coming right up. But I wanted to connect with you maybe later in the day today, just on a
Sure.
few things from this meeting. Will you be available just for a quick phone call, maybe around, I don't know, either like 2 or 3?
Yes, I will. Yep.
Awesome. All right. I'll talk to you then, Lisa.
And thank you so much for your help.
Oh, happy to help.
Bye.
Take care.